So as we know, Stapes surgery involves removing the Stapes superstructure and replacing it with a prosthesis. And according to the literature, there's multiple approaches and techniques in order to perform this. It has been proven in many studies to be a safe and low-risk procedure, and generally surgeons report good results with a low complication rate. The overall incidence of complications, but this is both inter and post-operative, is reported as about 7.5%. The important thing to remember, though, is even though the complication rate might be low, it can result in serious complications, and some of them might be quite devastating. And I'll go through some of those in detail in my presentation. So just to start off with, the question of whether surgical technique makes a difference to outcomes comes up quite frequently in the literature. And there was this big study published in the Laryngoscope journal a few years ago, which aimed to address that. So as we know, the surgery can be performed using a variety of different surgical techniques. And this includes laser modalities combined with use of a microdrill. It's been hypothesized that the use of a laser is actually less traumatic to the inner ear than a microdrill, and that's because of the possible noise trauma caused by the drill. There was these researchers did a retrospective investigation of the different techniques of Stapes surgery in relation to the hearing outcome and the risk for complications. And in their conclusion, they state that the combination of a drill and laser actually results in the best hearing outcomes. There were no major differences in any high-frequency hearing outcomes between the different surgical techniques, and the complications from surgery were actually very rare. And very importantly, patient satisfaction was very high at a year follow-up. So following on from this, what's important for us to stress is the perioperative counseling of our patients, because these patients need to be aware and prepared for any possible outcomes. So what they should be told is they should avoid any possibility of causing head trauma to themselves or having that occur. They should cough and sneeze with their mouth open, shouldn't strain against the closed glottis. They should avoid any possibility for barotrauma for at least a month. So that includes air travel as well as deep sea diving. They should avoid any heavy lifting. And if any of the following occur, like hearing loss, vertigo, or tinnitus, they should immediately report those. So I'll start off with the first complication, and that's a conductive hearing loss. This can be due to three things. Firstly, prosthesis displacement. Secondly, incus erosion, and thirdly, bony overgrowth. And I'll go through each of those separately. So in terms of prosthesis displacement, this occurs in the situation of a short prosthesis, and this can happen if a patient has to valsalva or sneeze. And what you do is, what happens is that you get contracture of the connective tissue seal over the fenestration, and the thicker the oval window sealant, the greater the lateralization of the prosthesis. You can also get traction from any scar or adhesions that have developed between the prosthesis and adjacent structures, and that can cause displacement. Moving on to incus erosion. So what happens here is that there's necrosis of the long process of the incus, and then this causes loosening of the attachment of the prosthesis and will cause a conductive hearing impairment. The hearing impairment may fluctuate, and importantly, necrosis can be distinguished from any loose attachment of the prosthesis through something like faulty crimping, because something like that can be easily corrected surgically. And then moving on to bony overgrowth. So this has been reported both within a year of primary surgery and even many years later. And it's quite unpredictable who this happens to. It generally occurs over the area you fenestrated. It's more common in cases of obliterative otosclerosis, which in general has the highest rate of complications. You get fibrous adhesions which fix either the ossicles or the prosthesis, and it's been reported in about up to a quarter of revision operations. And foot plate refixation may actually be encountered following any mobilization procedures, although it's quite rare to have these nowadays. Moving on to a sensory neural hearing loss. So this is actually the most dreaded and devastating complication. The incidence of a permanent hearing loss is reported as up to 3% in large series that have been done. Can occur in the immediate post-operative period or even weeks to years after the operation, which might suggest that these patients should be followed up slightly longer. When it occurs late, there's often no cause found and it's said to be idiopathic. And it's more common in stapedectomies versus stapedotomy and also revision cases. So what are some of the perioperative causes? Well, extensive drilling, which is generally associated with an obliterative otosclerosis, if there's any floating foot plate or perilymph aspiration, and also if there's congenital foot plate fixation and a CSF cushion, which you would notice intraoperatively. The delayed causes can be things like barotrauma, which is why we warn our patients about, caution our patients about any of these, reparative granuloma, perilymph fistula, and also suppurative labyrinthitis, all of which I'll go through a bit later. So moving on to a reparative granuloma. So what is this? Basically, it's granulation tissue that forms around the prosthesis and foot plate, and it may also extend into the vestibule. The incidence is different between stapedectomy and stapedotomy, but both are quite low. It is more common when a gel film or fat graft is used, and it really occurs when you use perichondrium fascia or vein graft. Clinically, how do these patients present? So they get a hearing loss, some vertigo, tinnitus, and also what you'll see clinically is a reddish discoloration in the posterior superior quadrant of the tympanic membrane. The typical picture is that you get and what patients will describe is that initially they get a hearing improvement, and they're quite happy. But then this is followed by a sudden or gradual deterioration in the hearing that can occur over a 1 to 6 week period. So I hope everyone can see the image, and this is not that good quality, I apologize, but an intraoperative image of the reparative granuloma. You can see where the black arrow is pointing, and it's completely encasing the stapes prosthesis. So there's different etiologies that are hypothesized of why this occurs. It can be infection, it can be a foreign body reaction, maybe Teflon particles that the prosthesis is made of. The management is what is important. So previously, most papers in the literature generally recommended early surgical intervention. However, nowadays, in contemporary management, most surgeons will advocate a more conservative policy. You give some steroids and antibiotics, keep the patient in hospital and monitor their response, and then you can consider delayed surgery if there's no improvement with this. Imaging in terms of a CT and MRI can be useful in assessing the extent of the granuloma, but isn't a must. And then middle ear exploration and removal of the granulation tissue is essentially the definitive management in someone who's not responding to conservative measures. The outcomes are generally split evenly between which the patient may either have hearing improvement, they may get stabilization, or they may actually end up with a profound impairment in their hearing. So it is something that you want to actively manage. Moving on to the perilymph fistula, so the incidence here is reported up at about 2.5% maximum. Following revision surgery, this is much higher, and it goes up to about 12%. And then one of the kind of principal investigators back in the day on Stapes surgery was a man called Shea, and he reported a perilymph fistula when he used a Teflon prosthesis and no seal is about 2.4%, and this was higher than when a seal was actually used. There was no one got a perilymph fistula in his series when a seal was used. Sorry. It is a very serious complication and potentially dangerous because of the risk of meningitis, and the hearing loss will progress if the fistula isn't addressed. The risk of this can be minimized by using a vein graft, making a very small fenestra, or an interposition operation. And the greatest risk factor for fistula is reportedly because of use of a gelatin spine, which is used to seal a stapedectomy, but this technique has largely been abandoned, thankfully. So how do these patients present? So they'll have a sensation of fullness in the ear, also some vertigo, a fluctuating hearing loss, non-pulsatile tinnitus, and 2 out of 3 patients will have a positive fistula test. In terms of the management, so can you allow spontaneous healing? The literature is very unclear on this, but generally what's advocated for or what's recommended is that to urgent re-exploration, remove the prosthesis, use a tissue graft to then seal the oval window and then replace the prosthesis with a new one. The literature generally reports that the earlier you treat the fistula, the better the chance of restoration of hearing. Otherwise, this patient will suffer with troublesome vertigo and possibly an irreversible sensory neural hearing loss. Okay, so going on to vertigo, this is, as many of the complications are more common with a stapedectomy versus a stapedotomy, and the reason is because of the risk of a serous labyrinthitis. The incidence is reported as about 5%. It's really persistent or prolonged or severe, and it usually lasts a few hours and can last up to 1 week. The management is generally supportive. You can give vestibular sedatives. If it's persistent or severe, it could be because of medialization of the prosthesis into the vestibule, which can occur, and then this may then go on to cause a perum fistula. Can be because of an associated reparative granuloma, and then also don't forget that BPPV has been reported in a small number of patients post-stapedectomy, and this was in one large study, and they reported that all of these patients were successfully treated with an epi maneuver. So don't disregard other common causes of vertigo in these patients. Okay, going on to facial nerve palsy. So this can be either immediate or delayed. Immediate generally occurs if you've injected local anesthesia in the region of where the facial nerve emerges, and this should resolve. Delayed can happen up to 10 days after the operation, and this is because of nerve swelling, and it's usually also because the nerve was, some sort of heat was applied, most likely indirectly by a drill or laser. Usually it's an incomplete paralysis, and we do expect full recovery. The management, so you can some surgeons opt to give steroids, and the palsy usually responds completely. A permanent facial nerve injury after Stapes surgery is actually very rare. This is because you can get a situation of aberrant nerves crossing the foot plate. You can get laser or burr injuries, as I've mentioned. And then also you can get a dehiscent canal during revision surgery, which is why imaging is important. Then there's the entity of discomfort to loud noise. So this is very common. Up to 41% of patients will report this. Some people seem to think it might just be a perceived thing because you've obviously improved hearing in the previously poor hearing operated ear. It frequently settles, but it can persist, and then comes up the issue or the role of stapedius tendon reconstruction. So it is very common for the surgeon to cut the stapedius tendon as part of the procedure, and why a stapedius tendon reconstruction has been proposed is that an intact stapedial reflex actually improves your ability to follow speech in the presence of noise. Whether this is done commonly or not, it's quite hard to find in the literature, but it is something you can consider and discuss if you're thinking about it. And then alteration in taste. I'm sorry for the image if it doesn't, if it's not that good quality, but essentially it's showing a tympanic membrane and the chorda tympani. Alteration in taste is as a result of stretching or mobilization of the chorda tympani nerve. The incidence is quite high, about 1 in 3 patients, and it's thankfully though usually temporary and lasts only about 3 to 4 months. The symptoms of this is that patients commonly report a metallic taste or even impaired or loss of taste. They can get a dry mouth or a sore tongue, and so symptoms are actually less severe when the nerve is completely transected versus whether it's partially injured or just bruised or swollen. And then finally, just a small note on cholesteatoma. So there have been reports of cholesteatoma in the oval window, quite rare. It's quite hard to find more detail on this, and the thought behind this is that it's likely due to an implantation cholesteatoma because of skin elements that get implanted during harvesting of any fat graft. And then just touch on meningitis. So meningitis has been reported following Stapes surgery. was particularly in the older literature, so it's not something that's seen very commonly nowadays, and that's because it was following a stapedectomy where there was fistula formation, and as we know now, stapedectomy is more commonly performed. The creation of a fistula therefore creates a route, the route for possible entry of microorganisms. This is treated as per standard meningitis protocol, so treat with IV antibiotics for a minimum of 10 days as an inpatient. And then some authors, however, quite strongly advocate for an exploratory tympanotomy to actively exclude a fistula in any patients with a meningitis and a stapes prosthesis, but this isn't actually the norm of practice or what people generally do, but it should be borne in mind that this is an option. And then I thought I'd just touch on the factors that affect your surgical outcome. So there's three main ones. So it's surgical experience, which I don't think is new or a surprise to any of us. I think that's pretty obvious. Also, perioperative administration of corticosteroids and also the use of a laser for foot plate perforation. So I'll go through surgical experience. There was a big study done which showed that the post-operative conductive loss we see that's caused by incus necrosis and prosthesis luxation was less often observed with surgeries performed by physicians specifically with greater than 6 years of experience. So that's quite a long period of time, which maybe highlights that these surgeries shouldn't, unless you have experience and support, shouldn't really be dabbled in by people with not enough experience. The next thing is that perioperative administration of corticosteroids. So as we know, steroids have an anti-inflammatory effect, and this is thought to inhibit any soft tissue reacting, also the formation of fibrosis, and is postulated to possibly lead to better outcomes. This is just one study that's shown this. It's not really all that widespread. And then the use of CO2 laser for perforating the foot plate. So this is thought to perhaps minimize the mechanical manipulation and damage that is caused during this step of the procedure. And it's been independently associated with better audiological outcomes. So that brings me to my conclusion. So as mentioned before, a stapedectomy is a very safe procedure generally, and importantly carries significant hearing benefit for the patient, and this has been reported by many sources. The serious complications resulting from any surgery for otosclerosis are still relatively uncommon. The many undesirable issues can be avoided by a very thorough preoperative evaluation, which includes thorough and detailed counseling of the patients, and also, of course, a meticulous operative technique by an experienced surgeon. So informed management, so knowing when to reoperate is also very important, and also when the option to manage medically must be emphasized. And this can actually optimize outcomes and give your patient a better outcome when a complication may arise. And it's also very important to be aware that of all of these complications, so that you follow your patients up appropriately, and also because some of them do require urgent or prompt surgical management, and this translates into your ability to possibly salvage this particular patient's hearing. So yeah, thank you for your attention and for attending, and these are my references. I think we can take any comments and questions now, if anyone has.
Yeah, thanks, Leila. It was a nice presentation following Louise's on Wednesday. Just kind of two minor comments. I think experience is one thing, but also consistency, like Tashlin reiterated. Many people feel they should be doing a minimum of 1 every 2 months, if not more. I'm sure that probably correlates with outcomes. And then I think it's also just be careful about what you see in the literature, like the blanket statement that I don't know what kind of research or the kind of quality of the research which supported use of the laser there, because I mean I think you need to like Louise's also reiterated on Wednesday, use the most appropriate instrument in that surgical scenario in terms of fenestration. So you don't want to be using a laser when you've got a biscuit foot plate, for example, because you're going to be creating a lot of thermal heat and potential injury to surrounding structures. And whereas I think the laser is theoretically, I don't know, kind of experience with it, but it's supposed to be beneficial in situations like these, like floating footprints. And also the laser, when I've seen it used, they're using it to perform the caroteny, and then they use it to partially fenestrate the footplate. Most of the time they still complete the fenestration with the scooter or small diamond ball or even the fenestrators. So just be careful about what you read. There's a lot out there in terms of safety.
Thanks, Matt.